You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
Oh, God. That's like
It's
seventh grade lunchroom.
Her and Ev.
Seventh grade lunchroom. And just, we love you, but nobody loves boiled hot
You're a
dogs.
chef. What are you doing? With
Is she a chef?
Well, basically.
Yeah.
She
What?
said it's not fair. You can talk and I can't. You can type.
Chat. You got chat. You just got to type quick. Okay. Week in review 33. This one's going to be a little bit different. To be honest with you, I thought it got a little stale when multiple cases were going. Just probably too much just case stuff. I can't defend myself. You can defend yourself. And the way I would defend myself is to not eat boiled hot dogs. So I'm going to do a little bit of a kind of lecture, but then tie in multiple cases and kind of have this, I don't know, guessing game. But I'm going to share let's go over here. So I gave this out to people that were in or have been to an Art of Assessment course. So this is the exam flowchart. Why I'm pointing this out is here in a second, I'm going to present three short cases. I'm not going to give you the whole case. I'm going to kind of give you the history, the synopsis. Then I'm going to go over what we're going over tonight. And I want you to kind of bank these cases in your mind and start using things like divergent thinking and this intuitive red hat, if we're using the 6 hats process, to start thinking just from what I told you in the topic of tonight, which one of these cases do you think are, what we're going over tonight is trigger point, radiculopathy, or nerve entrapment patterns, referral patterns. So I have a case that represents each one of those. You don't get a ton of information, but I almost guarantee you, just based off intuitive feel and the facts that I'm giving you, you can start to kind of figure these things out. I'm doing that for 2 reasons. So you can look at how important it is to follow your intuition, but also prove it with assessment and analysis and things like that. But also, so you can walk yourself through the process of maybe thinking that something sounded like radiculopathy when it was nothing like that, which can be extremely common, and not getting tripped up by that. I get that this is not, you don't have all the facts. That's not the point. It's just to kind of be like, yeah, that kind of sounds like it'd be this. Well, is it or not? We'll find out. So getting back to it, as I said, the topic of tonight is the differentiation between those 3 things. I would say it's relatively easy. I know some people maybe early in practice would not think it's that easy. I think the reason it's easy is you have to kind of go back to fundamentals of what's creating each one of these things. So I'm going to go through the cases first because I want you to kind of be front loaded with what's going on with each one of these things. So here we go. You got to remember these. If you want to write them down, maybe I could type them in the chat. I don't think I can type that fast, but that's okay. So we have a 15-year-old female track and field athlete that has heel pain that came on in the last week to the point that she had to stop running during the workout that she came to see me, the night that she came to see me. She's dealt with medial tibial stress syndrome over the past 2+ years on and off, which we've been treating her for. Prior to track and field, she was a dancer/gymnast, and that's all you get. So she has all of these people have heel pain. That's the commonality. Okay. Second person, 42-year-old male, and they're all runners, has started running over the past few months and notes that his right heel is to the point where he can barely make it a mile before he stops. He has been foam rolling his calves and stretching. Upon questioning, he has a history of mild low back pain with intermittent flare-ups. Also states that he has flat feet and uses orthotics. 53-year-old female trail runner was put in a boot a few months ago due to, I'm air quoting, Achilles tendonitis. Has really upped her mileage over the last year. She had a laminectomy 20 years ago, lumbar laminectomy, L4. Notes that she is also dealing with left knee pain. It's on the same side as the Achilles issue for the past 2 to 3 weeks. She's been going to PT for Achilles for the past 5 to 6 weeks with no real change. So listening to each one of those, knowing that the choices tonight are radiculopathy, peripheral nerve entrapment, cutaneous nerve, same tonight, or trigger point referral. That's your 3 options. You should have some feeling of each one of those, which one is which. Big reveal later. Okay. So let's share this. I think this will be better. Okay, so this is a slide. Let's hit the play button so it looks a little bit better. Maybe. That looks the same to me.
Same, but different.
Cool. Let's share this then.
Samesies.
Okay, so this is something I go over in Art of Assessment of after we've kind of went through the soft tissue assessment portion and we went through trigger point, nerve entrapment sites of the upper extremity, which I might go back through those here in a second. But I just try to point out that we have some easy things to start differentiating what's causing this referred pain. So the first one would be, well, you can have a central component. Well, then you want to say, okay, what are all the things that can create a central component that can refer pain? What do you guys got?
Discogenic.
Boom. You have some sort of cord impingement, lesion, cystic change, or you can have some disturbance of the nerve root. Foraminal encroachment, assist on the nerve root. You could tear your nerve root if you're a local PT that's had cervical issues. Shit happens, I guess. Crazy. Crazy. Everybody needs a drink on that one. Or you could have peripheral. And I'm trying to make this like very like, this is what you got option wise. So you're like, oh, all of these presentations, you're like, this is the only thing you kind of got. And we go back to school and say, what, tumor infection, whatever. Yeah.
Pleonasm.
Yes.
Pleonasm.
It's not even. Pleonasm is using too many words to describe something.
I know.
Seth knows that, but yeah. It's an asm. Peripheral.
It's not an ism.
Neuropathodynamic, trigger point, and I'm putting entrapments and all those asterisks because technically that includes neuropathodynamics. Just if you have a cutaneous nerve irritation, which I did a interview with Dr. Philip Snell today, which he kind of talked about maybe there's a prodromal peripheral nerve irritation that's causing altered soft tissue changes and then thereby altered arthrokinematics. So maybe it's not backwards from what we originally thought, but maybe there's some other mechanisms at play. So I could even throw that into neuropathodynamics and just say neuropathodynamics, trigger point. And when you distill it down to that, you're like, yeah, maybe I kind of feel like I'm overthinking things too much. So I use this as just a working exercise. We've already went through the 6 hats process, which we haven't talked about yet, but the 6 hats is this book we talk about by Edward DeMono that goes over let's see if I can remember them. It's been a while. Maybe Seth, you might have to help me. The blue hat is your process hat. It keeps you on task. The white hat is what we call our audits, our objective data hat. The red hat is intuition. The green hat is divergent thinking. That's kind of this explosion of thought. The yellow hat is convergent thinking. It shrinks it back down. And then you have the black hat that is things that could be going wrong, red flags, initial in the case, or pivots later in the case. Using that process, the first thing that needs to happen if somebody came into your clinic with this, they're saying, hey, I have pain in the ventral aspect of my forearm and it goes into my first and second digit. So that's what they're telling you. Okay. So then you as a clinician are supposed to have this divergent brain explosion moment. They could say, it could be a radiculopathy, C5, C6. We talked about that. Cool. It could be a trigger point from any of these muscles. But when you get into the specifics of some of these trigger point referral patterns, you're like, oh, that doesn't really make sense for going all the way into the digit. Maybe it's into the thumb. Maybe it's just the wrist. So you could say, oh, these kind of look like it because they'll mimic this kind of, referral pattern, but it's not exact. And they would say, yeah, neuropathodynamics, radial nerve, and then the cutaneous nerves off the radial nerve. Could be anything like that. And then your exam, right, going through range of motion, soft tissue palpation, joint palpation, neurodynamics, you'll start to suss out which one of these is McKinsey, all that. Get it. Cool. Cutaneous nerve, like we said, lateral antebrachiocutaneous. So I just wanted to go over that to show you we could take all of this, we go over all of this fancy stuff in Art of Assessment to show you all of the options, all the nerve entrapment sites, all the cutaneous nerves. Radiculopathy, pretty easy to determine what's going on if it's associated with what?
Neck pain.
I would say motor weakness or reflex changes. And you're like, oh, that's legit radiculopathy.
Yeah.
Because you're not going to get that with trigger points now, peripheral nerve entrapment. Maybe you could say you get some weak. I think that would be hard pressed for weakness for sure. Dysesthesia, paresthesia. You can still have that with trigger point, right? You can still have that with nerve entrapment. And then the hard thing with nerve entrapment and trigger point is like they're probably together all of the time. Yeah. So then saying, oh, it's this or this, and maybe it's both, and then you're just having an intervention point. So instead of using like a neurocentric dermal traction-y kind of cutaneous nerve. You focus on the trigger point. And that was kind of cool. So look forward to that podcast with Phil Snell, because that's kind of what we talked about today, which I didn't know that was what his thinking was. And he had some interesting input on that. So breaking it down here, how do you determine just off hearing these short synopses of a case, right? Because when somebody is entering your clinic portal, we always talk about, well, we want to start having some sort of intuitive, right? Some sort of stereotyping. And we talk about in art of assessment how that's not a negative thing. Some stereotyping of what's going on. And then you play the game of proving yourself right or wrong, hopefully right. Well, by the time somebody's walked in my office and told me stuff like this, which goes beyond the paperwork, or if it's a react or reactivation, which all of these were, you can say, well, trigger point is going to be, you can pick a lot of things out of the history. So in your guys' opinion, what are some things that would be commonalities that people may tell you if a trigger point is the culprit for some sort of referred, how it presents, date, time of day, activities, things like that? Is there anything that sticks out?
It's probably worse after the activity.
Yeah.
Well, I guess.
Go ahead.
I was thinking like what it might present like in the history, like if you were doing more, if you had a change in your training volume or something that was abnormal.
Yeah.
Like you just ran a lot more, or I don't know. Maybe you ran trail and you're normally running road.
Yeah.
I say if they also feel like they stretch, and then it kind of feels a little bit better after they do that, but it comes right back.
Yeah. Or maybe they can hit a spot with a lacrosse ball or something, even create referral, but they're like, it just doesn't go away or something, which again, we're not saying that's what it is, but all these things should start like, again, divergent, where you're like, oh, I got to like lean into that. Well, actually, I guess that's convergent. So if you, mind explosion, then you hear these historical things, you're kind of already chopping in your mind. The thing that you can't do is what? Skip ahead in your exam and all of a sudden you're like, oh, missed that thing, right? So I'd say history, things like Alex said, we call it sub-threshold nociceptive input, right? They're doing a lot of work. It doesn't really cause pain, but all of a sudden that muscle's being overutilized. Maybe, as Phil Snell talked about today, it's actually peripheral sensitization of the cutaneous nerves that then alter motor output. Probably both. I would say if you know your trigger point referral patterns, they have relatively defined patterns. So it's one of those things when you start to learn them, you're immediately in your head when somebody's like, like they'll literally with trigger point stuff, they'll draw like the referral pattern. Whereas like radiculopathy and stuff, I mean, they're usually just like, oh God, it's like, it's just, that's why I even say like radiculopathy sticks out like sore thumb. Like it's just, you're going to know it. And then if it has, like I said, myotomal or reflex changes or anything like that. So learn those patterns, realize that they're not exactly the same on everybody. They're not the exact same in every case. How do you elicit a trigger point response?
Push on it.
You palpate that bitch. You push on it. Is it always going to refer? No. Is it going to cause local pain even if it's not the culprit? Probably. So that's where you got to make sure that like it is the thing to work on. And is it a trigger point? So if you think it's anterior scalene and you go up and there's no trigger point there, it's gone. Like just that easy. Don't be like, I don't know if it was a trigger point. Just early in your career, make decisions. You might be wrong, but make a decision. Otherwise you have, how bad would it be if you ran an experiment and you're like, I don't know if that variable worked or not, but I'm going to go do another experiment and keep that variable in there. And then you keep adding variables, personally, like you don't even know what the hell you're testing. Just make a decision. Maybe the wrong experiment, but at least you ran a clean experiment. Anything else on trigger points that you guys would add in?
I feel like another presentation that you'll see, maybe if it doesn't reproduce the pattern or they don't feel like it's tender. If I think there's a trigger point and
they
it
don't
twitches,
realize it's
like I think a lot of times seeing people with like that TL trigger point on an erector, they'll like literally twitch to the side.
Yeah.
And didn't know that was, I didn't think that was tender.
That tender.
Yeah.
Yeah, especially your back, because I mean, the feedback, like sensitivity of your back and stuff. Yeah, that's a good point.
Almost like a ticklish type feel.
Yeah, which you will get,
I feel like that could go on any, I don't know, sometimes like the peripheral nerve as well. I feel like that can also get a little tickly.
Well, that's what I was going to say. Like I try to explain to patients, like ticklishness is like altered neurofeedback. Like you're heightening your sensation because there's altered perception. So the best thing to do to protect it is make it ticklish. Everybody's like, really? Like think I'm lying or I just make up stuff to like make my day fun. But that's why kids are relatively ticklish. Their nervous system is still developing. So they're trying to like pick up better feedback. Anything else on trigger points? No? Yeah. And with all of these, I'd say trigger points the least out of all of these. Treatment is part of the diagnosis. I think if you're sticking a needle in a muscle to determine if a trigger point's going on, you are terrible at your job. You should be like, yeah, it's kind of tight. And like, no, you should be like, dude, trigger point right here, like light it up. If you're not to that point, like you shouldn't be using, heavy tools like that.
Are we going just purely off of history right now?
For the cases?
For what a trigger point is? Like, or what we're talking about, like trigger point.
Oh, no. Not at this point. No.
I feel like reduced range of motion can't.
Yeah. That's a good thing. Yeah, I would agree. But I would also say that any of these can create reduced range of motion. That is one tough thing. Because if you have cutaneous nerve, like if you have a nerve entrapment, that's technically a pathoneurodynamic, which an overt sign is reduced range of motion or overt abnormal test, right? Radiculopathy, maybe it's pain that's reducing. It's not a legitimate, reduction without that. Yeah, I'd say that's true most of the time. Yeah, I'm trying to think of anything else. If anybody has anything, let us know. We'll move on to radiculopathy. History, huge one. I would say 90% of the time, radiculopathy is not going to show up overnight. It's going to be this kind of creeping thing that's getting worse and worse. I mean, sometimes you have that kind of like, I slipped on the ice, fell and slammed my neck into, extension, rotation, lateral flexion, and they smack a nerve root or something, or, protrude a disc. But the history is also what? Positionally, that not that a trigger point couldn't be, that positionally this thing just lights up, right? That it also may have what? Like some sort of alleviating position versus a trigger point. I mean, there's not many things you can do to get away from that thing once it's you're just like, oh my God, like that's why people want to jab something in. Radicular symptom, if you have something besides a extrusion or a protrusion or sequestration that's like out in the canal that cannot be, worked on mechanically, you can usually move yourself in a position where you're like, yeah. And that's what people will tell you. That would be the big historical presentation. That's why you come in antalgic. You're trying to offload or open the foramen or open the lateral, canal. So that'd be the big history point on that for me. Obviously, if somebody tells you, it's getting hard for me to walk, so my foot slapping on the ground, you're going to see all the neurologic signs, heel walking, toe walking. If anything like that's off, you're going to get it. I don't think we need to go over that. So I have in here, dermatomal pattern. I think you should know your radicular patterns, just like we get taught in school. Like I said, associated motor weakness, reflex changes, orthopedic findings. So I'm saying orthopedic because those are sometimes testing for radicular patterns. Like what? What's an orthopedic test where it's mainly to suss out a radicular symptom?
Slumps.
Maximal foraminal compression. What else? I mean, I guess on a lot of cervicals. Yeah, Kemp's. Yeah, maybe. Yeah. I'd say, maybe more sclerotogenous facet driven referral, but yeah.
I don't even know if there's a real name for it, but whenever we do the straight leg raise where you close the foramen.
Like bananas?
Yeah. Is that like an actual?
It's like it's modification of neurodynamics. Yeah. Okay. Which neurodynamics means straight leg raise slump is neurodynamic. Maximal foraminal compression is a rare one because you're just closing out the canal and kind of seeing if it pegs them. And then I would also say with radiculopathy, like we were saying, and alleviating position, if there's a directional preference, which if they tell you or you find one, so that gets into the treatment, can be part of the diagnostic process versus the trigger point. I would think that's somewhat the case. Peripheral nerve entrapments, as I said, I'm going to throw in cutaneous nerve irritation, sensitization, entrapment in there because I think that's mainly what you're going to see if it's just an entrapment. History presentation with this is, I would say, largely activity dependent. So you have a nerve entrapment. It's usually like I go play tennis and I get radiating pain down my arm. I run for a while. My foot starts to burn down, the side of my ankle or something like that. You can have it positionally, just like you could have with radiculopathy, a little bit of trigger point, but I'd say it's more activity driven because of the interface, right? If you're testing neurodynamics, it's usually a big dynamic movement. The other thing is, I asked Brett Winchester about this. Michael Shacklock talked about it when I had him on the podcast a long time. You usually have to have two areas of entrapment to have a true nerve entrapment because you're tugging on it at both ends. So that's like a it's not moving well in an open and closing dysfunction. And then you have some sort of trigger point or fascial distortion in the periphery. So what I would say is you can also get this with static positions like sleeping, which is all of these would come on with static positions. I mean, how many people are you sussing out around shoulder stuff? I fall asleep and like my hand, well, now it goes down to pattern, right? Well, you could be cutting off oxygen supply. The muscle can't move. You could be closing down the frame, and you could be, closing down brachial plexus. Now you get that second, all of those. So that history piece, maybe not as much, but I'd say the activity for sure. Also, I don't know if I've ever had a case where I was paying attention enough that if they have a true nerve entrapment, they're not pointing right to where like a cutaneous nerve perforates the superficial fascia. Like if you pay attention, if somebody's like, dude, it just feels like I should. But if they're doing this kind of stuff, and if you're not watching the video, I'm just rubbing vigorously over an area and it's a cutaneous nerve irritation, what are you probably doing? Pissing that thing off. But that's what most people want to do, right? With those, whether it's, around the anterior hip or around, the elbow, the knee. Maybe we don't see people crushing stuff in their knee, but, foam it's not out of their quad or stretching it. Again, stretching in these scenarios, probably not going to be the best thing ever. Could be associated with latent trigger points. What I mean by that is if you don't have an active trigger point, that would be something that's creating the pain. A latent trigger point can alter, like we said, motor control, muscle output, joint arthrokinematics, and then pretty soon, what are you doing? That nerve is getting tugged on or pulled around from both ends, and that's where I think latent trigger points. So then you have a decision to make, as I talked to Dr. Snell today, of what your intervention point is. The Stecco model would say, hey, you got to get the myofascial slings moving so that nerve can move through them. I'm not saying versus, but maybe another approach is, hey, we desensitize the nerve, and maybe that like desensitization of the nerve calms down the rest of the tissues. I don't know. Pick your poison on that one. Associated skin findings. Talk about all the time. Skin tension, your ability to actually like roll the skin and pinch the skin. Trophodema, so that's that orange peel effect in the skin if it's got a lot of, or it hasn't moved a lot, and you kind of get lymph kind of trapped in with that superficial layer. And then just with any of these treatment findings, so if we use a neurodynamic test, and you get a over abnormal test, you're probably going to use neurodynamics to jump in and treat that right away. I would say most of the time. So then you treat it. If you have a positive outcome, then you just solidified that, as most of these would. Anything to add on peripheral nerve stuff? I'm trying to think. And again, like DTM, dermal traction, is I would say a pretty good diagnostic thing. If somebody has pain when they extend through their low back, and you just grab their, the skin over L4, L5, and you have them do the same thing, and they're like, yeah, I don't have any pain. Might be a good indication, like cluneal nerves are being irritated. Now, is that the only thing? No. But like if I can change pain, I may change input, which changes output. And now here we go. We're on this like cascade. Anything else? Now, one thing I will say on all of these, each one will garner a different treatment intervention, but then each one of them also garners different homework and adjunctive care. So a trigger point, great thing, let's say you find a trigger point in somebody's infraspinatus, and we do a little bit of DNS, you throw some needles in it. You may say, hey, for the next day, don't do anything with that, but then like, let's Stecco around it. So I teach people a lot now that if, the microphone is the trigger point, that we can work on both sides of that microphone instead of working right on it and kind of pissing the trigger point off, and get that kind of, the hyaluronin running through there, get the fascia, heated up a little bit next to it. And you may just kind of keep that thing at bay. Because again, maybe we haven't had enough time to change motor control or whatever's causing the trigger point in the first place. Radiculopathy, you're probably not going to send them home sticking a lacrosse ball in there in between their shoulder blade if they got radiating pain. What are you going to be sending home? Probably in-range loading, McKinsey-esque stuff. Probably not a great time to send somebody home with nerve flossing or something like that. So again, you can see once you have a clear diagnosis, or you can like name like, hey, it's this tissue that I think is causing it. And then, there's functionality that you're going to work around it. There's do's and don'ts with all of these. Peripheral nerve entrapment. This is where like taping and DTM, skin rolling, yapping, all these things come into play. Voodoo floss, where you can be like, man, you can really crush symptoms. And again, especially after listening to Dr. Snell today, I mean, maybe a big deal here is desensitizing the periphery to change output, right? Instead of always thinking like the periphery is sensitized because of something happening from the inside out. And that's the research that Dr. Snell has been really diving into. So there's some interesting stuff that he's looking at that when you put a very strange but intelligent mind on something like that, he'll come up with some interesting outcome. Okay, anything else? Is there anything else that causes referral patterns? For sure. Cloward signs, the discs themselves. We looked up some what was the ligament referral pattern? What was that guy's name? This guy's name. We found a ligament referral chart, and I was like, yeah, don't even worry about that.
Claire me.
Yeah, we'll look it up. Sclerotogenous referral patterns, visceral referral patterns. I mean, the list goes on and on. Most common culprits is what we talked about tonight. I would say the one thing to watch out for is making sure in your history that you don't have some viscerosomatic referral pattern going on. The big ones, heart,
Gallbladder.
Yeah. And big ones like common gallbladder, like don't let somebody, die of like a heart attack or a clot or something. Cause you're like, oh, your whole hand's numb. And you're like, yeah, let's work on this trigger point. Okay. Your arm's a little red and swollen. That's okay. So be a physician, or that should be taken away from the second part of your moniker. So let's roll these out. So again, to review, we had the 15-year-old female track and field athlete with heel pain, weak onset, 42-year-old male that started running over the past few months, has right heel pain to the point where he can barely run, history of some mild low back pain, and a 53-year-old female trail owner that was put in a boot a few months ago due to Achilles tendonitis. Now I'll add something onto hers that kind of does matter. So maybe I slow played you. When I heard that she was in a boot, now she's in my office, she did PT and they said it was Achilles tendonitis. I just asked her, was it red or swollen or, hot or anything like that at any point? No. So you could just firmly tell that patient you never had Achilles tendonitis. Did you have some sort of apathy with your Achilles? Maybe. You definitely didn't have inflammation if you didn't have inflammation. So you didn't have the itis.
Get the itis.
Why is that important? Because dumbass doctors need to quit telling people shit that's wrong. That's why. And don't let them get away with it. Now, don't be a jerk. I didn't want to make her feel less than or dumb for having been put in a boot or listen to them. She's not. She did what they told her, and that is why she did it, because they hold authority. It's not on her at all. But now that she knows, if she has encounters again, it is on her. So that's one thing. There was no inflammation, but I think that most people listening to this podcast, if we had somebody with Achilles pain that got stuck in a boot, you'd already be like, yeah, I'm calling bullshit. So here's the big reveal. So the 15-year-old female track and field athlete, honking trigger point in her medial gastroc, needle that puppy, literally walked out of the office, no pain, and ran a track meet 2 days later. That was Thursday. So how do we pull that out of that one? She dealt with medial tibial stress syndrome. So maybe there's some mechanical things that she likes to really get out in front of herself, maybe use the lower compartment a little more if she had. Where was I trying to mislead you? She was a dancer gymnast prior to getting in track and field. So now you already know that one of these other two isn't a trigger point thing, but maybe she had some low back stuff. And you're like, oh, I got to make sure I really rule out the low back, which you do. But I've seen her for a long time. And I went with the most common thing and I palpated that and it referred pain into her medial heel. And I was like, I think that's it. And I know her history because I've treated her so much. So I didn't go back. Maybe I missed something and treat her low back. I threw a needle in that giant trigger point that had her referral pattern. It was gone and it stayed gone. Now, if she was a brand new patient, it's a different way to approach that. The 42-year-old male that started running had heel pain. I was a dum-dum on this one. So he comes in the first visit. I do some foot stuff with him because he can't do anything with his feet. He has no, toe yoga is all off. I do that. Comes the next time, he's like, I'm kind of the same. And then in office, do a bunch of press ups. He gets up, he walks around, he goes, my heel doesn't hurt at all. I'm like, oh, cool. I'm like, I should have paid attention to him telling me that I've had mild low back pain. Now, he didn't say severe things. He didn't say he had a laminectomy, right? Which would red flag you. This intuition's coming, but he did say he had back stuff with intermittent flare-ups, and he has flat feet and orthotics because I got led off course by that. Now, let me pay attention to that, right? And he was asking me about shoes and what shoes he should get. So he played a poker hand and I bit. So did some McKinsey-based stuff, worked on some breathing stuff. We worked on some hinging because he was doing a little cross training. I haven't seen that guy in forever. Hopefully he's still running, but I saw him 6-7 times. He's doing awesome. 53-year-old runner. We only got one option left. What is it? Peripheral nerve entrapment. So put in a boot a few months ago with Achilles tendonitis. Where was her pain? I don't have the foot model. I should have shown it. Alex, you should just strip your sock off. No. If you go on, so I don't know if you can see this, but low. So we're saying below technically the insertion of your Achilles on the medial and lateral side of your heel. It's technically not even your Achilles. We're not in your Achilles. No inflammation, not on your Achilles, but you have Achilles tendonitis get thrown in a boot. And it was on the medial and lateral aspect. And she goes, the worst thing that I could do is squeeze it. Well, what's one thing that squeezing your calcaneus medial or lateral could be indicative of? Stress fracture. It's actually the most common or the best test. But also what lives on the medial and lateral aspect? Well, your lateral and medial calcaneal nerve. Yeah. So they drape off that. What do they come off of? Tibial nerve. What was she also dealing with? Knee pain. Where did I get led astray with her? I didn't get led astray. I hit this one on the head, but I treated 2 prongs. She had a laminectomy 20 years ago. So I asked the question if you had any back pain and the main thing going on, because it hasn't been getting better. She's been doing PT and all this other stuff. So she goes, yeah, 2-3 weeks ago, my knee started bugging me where I can't flex it without it being really tight through the front. So I go, you know what? Let's not really treat your heel. I was almost certain that it was, a peripheral nerve entrapment just based on presentation. I mean, there's when there's no other anatomy there to cause pain, you kind of got to be like, that's got to be the thing causing it. So I said, hey, I'm not going to treat your heel. I'm going to tape it, right? So palliative stuff. We think it's nerve entrapment. I'm going to give you knee gapping flexions because we determined on orthopedic tests that nothing was really going on with her knee other than, restricted motion and flexion. And then I was like, you're going to go home and do extensions for, 2 days and just see what happens. So she came in today. She did extension for 2 days. Nothing happened. She did the flexions in her knee. She said she also did some other stuff, and that's probably where her knee was better. But her knee was pretty much better. Her heel, interestingly enough, was better with the tape on and then worse than it was before when the tape came off. I don't think it was worse. I think she just had a refractory, oh my God. Good. Yes, exactly. So then she comes in. Well, how do I know it's better? Because I could palpate it and there was no pain today. So today we did all the peripheral nerve stuff, voodoo floss it, moving it around, taught her a tibial nerve flossing maneuver. And then that's what I sent her home with. So that, again, all of them heel pain, all of them runners, all of them you could think like, oh my God, that's a low back case. Oh my God, that's, whatever. Your intuition will get better and better, but it's not like I hit a home run with the 42-year-old dude, right? I was like, let's work on your feet. And it took me a visit to be like, hey, stop. I should have ruled out his low back. That was a new patient visit. I didn't do due diligence off of the history and the exam. So
where are you thinking the knee came into that after the fact?
Probably
I get the entrapment.
altered running from which she said that her heel never bothered her when she ran. I mean, she was literally she couldn't jump without pain.
Wait, but so she's in the boot.
She was so she had Achilles pain in November of last year. She got out of the boot around Blood Rock, so right after Blood Rock.
She wasn't in the boot when she saw you.
Yes.
Okay.
She's been out for a while. She did PT after the boot. So she was in the boot for about 3 weeks, then did 5 to 6 weeks of PT after that. They told her to just rest and wear the boot, which is also insanity that you don't do PT while you're in the boot. I don't know.
10 inches magically.
Yeah, it just gets better.
It just gets better.
That itis that wasn't there just going to go away. Just got to get a job. You go do your thing.
Stop freeloading.
Yeah.
Yeah. I don't know. I thought this was kind of we did this way back when in Grand Rounds. I kind of did this multiple choice. What do you think's going on? Any input on any of those or different thoughts? And again, I gave you very little information on purpose. I didn't want to go through entire cases and suss it out. That's not what this is about. It's how do you make a differentiation? Because this is the stuff you're going to see the most. And Snell said today, this is a bulk of his referrals because he's built a practice on people know that he deals with neuro stuff.
Yeah.
So that's a lot of his referrals. Well, I think you could just you could be able to practice on gymnastic specialty, feet. You could very easily be dude, I'm really good at sussing out these, paresthesia referred patterns. People are not good at that at all. In our profession, definitely in other professions, they're absolutely terrible. If you can point at pain, these are all heel pain. We don't think of those as a referred pain. We're pointing at their heel. When you draw this radicular pattern, most physicians are going to go, it might be your neck. Well, maybe it's not. And that's where you can differentiate yourself. Now, how you sell that or market that, that's up to you. I don't know. I say you get one of those body suits and start doing YouTube videos like on yourself, like the muscle suits. Yeah. I think that'll do really good. Yeah.
Sticky note yourself.
What? Sticky note?
Yeah. Make yourself a cadaver lab nerve model. Actual pins. Yeah.
And then you can actually pull out your entire nerve.
That'd be nice. That'd be nice.
Relocation. Yeah.
All right. Well, that's all I got tonight. I wanted to fast and furious with this stuff. I didn't want to go another hour and 15 minutes. I'm assuming, I don't know, boiled hot dogs is on here still. Kaylee and 2 other people, or 1. I think it's 1 plus 2. So the sad announcement is still here, thriving on boiled hot dogs. She's probably eating a hot dog right now. And it's probably delicious. Actually, Seth and I were saying best hot dog, ballpark hot dog, wrapped in foil. It's been marinating in its own juices, so the bun's a little bit soggy to where you could literally just Kobayashi that thing and just one bite. You don't like hot dog?
He doesn't like. He doesn't like hot dogs. That sounds fantastic.
Yeah, I used to eat hot dogs raw when I was a kid, like with my job.
Raw.
Oscar Myers, go in there and steal one, think you're getting away with something? Oh,
yeah.
I'd be out of there. Gone.
You can pipe down about 3 hot dogs at a ballpark in less than 5.
I could do a brat.
Did you guys ever microwave hot dogs when you were kids?
Nope.
Just those things explode.
Hot dogs did not happen in my house.
They happen in my house.
You know, it's technically a superfood.
Sure it is.
He literally looks peaked from talking about hot dogs.
He literally had a puke. I think the next round of rounds we have Alex eat 3 hot dogs. See what happens.
Kaylee said at least I didn't eat carnitas for literally 16 months straight.
Too bad we've gone beyond that.
Not by much, Kaylee. Don't let him fool you.
16 months.
16 months ain't that long. I've been going on beef for a bit.
And we're about ready to split a cow between the office, so
we're about to beef it up.
It's just gonna.
Well, no, there's gonna be different cuts in there.
Oh yeah. We're about to buy a grill, Kaylee. We're about to get sophisticated in this house.
But the disappointing news is this is gonna be the last live one. I especially love Kaylee. She's been here for every one of them. But we have to schedule these around our patient load, and we try to do our best to make them amenable to everybody. But I mean, I'm just being honest. It's not worth it for this few people. So, Kaylee, if you want, Alex probably has your address or something. I'll send you like a hoodie and a hat and stuff for being a beast and always being here. If the other person that's going unchatted wants to represent themselves and you've been representing, I'll do the same for you. But we'll keep doing these. We can do them live. I'm just not going to try to make them at times that work for people. So it may get announced 5 minutes before. I'll still go live like this. Jaden's still here. Appreciate you, bro. And so there'll still be the opportunity. It's just not going to be like a week in advance. I don't know. Somebody's hacking the system. They heard that we were shutting this down. My camera just bugged out. So we love y'all. We'll still be doing residency stuff and releasing videos, but most of that's just going to go on YouTube now. I think it's just a better way. I'm going to leave the Facebook forum up. I want to keep having chats. And I think we had 2 people that commented on the what's your exam flow. So, yeah, keep posting stuff in there if you want to. If you still want to present a case, I'll still leave that open. You can go fill out the form or get a hold of us or something like that. And we'll see what goes on. Now there's 5 people once I announce that it's going downhill. So, yeah, that's how it goes. But we love you. I don't know when the next one's going to be, probably in 2 weeks, but it might be, I don't know, it might be at 10 p.m. at the farm when we're all just turned. So we'll have to see.
10 p.m. I'd be upside down.
Turn burnt. Yep.
I'd be upside down at 10 p.m.
Don't you have a baseball game or softball game yet, though?
I'm
sure
8:30.
I'm sure we could go ask
early
that dude over here in the Narrows for his inversion.
Yeah. He probably has no idea we exist. But
Yeah,
I
right.
ran past a guy the other day in the neighborhood that's literally probably 200 or 300 meters away from the front door of this place.
No clue we exist.
No clue we exist. And he's hanging upside down on an inversion table in his garage.
Seth was about ready to go in there and Batman him. Just punch him right in the back, adjust him, walk out.
Kick his knees backwards.
Get more of that. Yeah.
Yeah.
But we do appreciate everybody being on here tonight and everything before. And like I said, we'll keep doing these. Just they won't be announced quite so in advance, but look for those in the Facebook page when we do have a podcast coming. Without further ado, see ya.
Thank you for tuning in. Please subscribe via YouTube, Apple Podcasts, or Spotify. If you like the message, please share it. We appreciate it. Thank you.